Good afternoon, class. Today we are looking at cholinesterase inhibitors. Cholinesterase inhibitors are drugs that inhibit the actions of acetylcholine, which is our neurotransmitter. What happens is one signal transduction occurs, the acetylcholine, which is stored in the presynaptic vesicles, released into the postsynaptic space. And the free acetylcholine within the synaptic cleft is broken down or degraded by the enzyme called acetylcholinesterase. That means this enzyme will get rid of the acetylcholine and its effects will never be felt any longer. This enzyme, as well as no excess of acetylcholine, remains in the synaptic cleft to cause the continuous activation of receptors. So let's look at the diagram on the right, maybe to help understand more what we have just been explaining right now. So we have the presynaptic space and then the postsynaptic space, and then we have the synaptic cleft, which is the space between the presynaptic and the postsynaptic space. These are the spaces within the neuromuscular junction. So this is the nerve. Okay, this is the other side of the nerve, and it's transmitting signal through the synaptic space to the postsynaptic space. So what happened is acetylcholine is first of all synthesized, and then it's a combination of choline plus the acetyl group to form this acetyl coenzyme A to form the acetylcholine. Now, once acetylcholine has been synthesized, it's stored in what we call vesicles, okay, within the presynaptic space. So this vesicles stays here and awaits the release of signal. So when a signal transduction occurs, which normally occurs together with the influx of calcium ions, the vesicles will move and release acetylcholine. It will rupture, the vesicles rupture and release acetylcholine into the synaptic cleft, and then this acetylcholine will be received by the receptors in the postsynaptic space. Okay, the postsynaptic receptor will receive it, and then axons will be triggered because already the neurotransmitter has been released and is received at the other side. So all the axons of acetylcholine will be expressed. So what happened is the cholinesterase enzyme acts in between here within the synaptic space, and then it destroys the axons of acetylcholine so that no signal transduction can go. No effects can be felt because acetylcholinesterase destroys the axons of the choline, and then we may not feel the effects that should have been induced because of its presence. Uh, we look at acetylcholine degradation still and the clinical uses. So we said the pathway envelopes acetylcholine through the enzyme acetylcholinesterase will be broken down into choline and acetic acid as we saw already in the diagram. Blocking degradation boosts acetylcholine levels, leading to effects similar to the muscarinic agonist. Okay, inhibition can be reversible. For example, drugs such as neostigmine, physiostigmine, and erophonium, they can bind, but their actions can be reversed, can be reversible. But there is another drug called ectothiophate. This one it binds permanently to the receptor and it can never be reversed. It is an irreversible binding. Clinical uses of the reversible inhibitors are used in treating diseases like the myasthenia gravis. We shall talk about myasthenia gravis in the coming slide. We looked already at Alzheimer's disease, okay, and then reversing the neuromuscular blockage postoperatively and treating anticholinergic overdose. So it can be used as an antidote actually to overcome overdose due to treatment with anticholinergic medications. Here we are saying the accession is a tricyclic antidepressants like amitriptyline, for example. Reversible inhibitors such as physiostigmine can cross the blood-brain barrier (BBB) for treating the anticholinergic overdose. Okay, let's look at irreversible inhibitors and toxicity. Irreversible inhibitors such as the ectothiophate are used solely for glaucoma treatment. Glaucoma is a condition affecting our eye where there is increased pressure within the eye. within the eyeball, so leading to a condition called glaucoma. Toxicity associated with malation is an insecticide, and saline nerve gas exposure. So still, this one can also be used in this particular condition. We look at adverse effects and toxicity. Similar adverse effects are seen as in the muscarinic agents. High dosages can lead to respiratory paralysis and cardiovascular collapse. Treatment for toxicity is usually by giving atropine, or we can use mechanical ventilation. Let's look at myasthenia gravis. By definition, myasthenia gravis is a chronic autoimmune disorder in which antibodies destroys the neuromuscular junction, resulting in weakness of the skeletal muscles. Again, let's look at the diagram on the right to be able to understand uh, myasthenia gravis more. So we said this is the pathophysiology of what happens in myasthenia gravis. So we have the normal neuromuscular junction in this diagram, and then we also look at the impaired neuromuscular junction in a person already having myasthenia gravis. So once again, we said it affects the neuromuscular junction, it affects the nerves, and then the muscle. So this is the neuromuscular junction is the connection between the nerves and the muscles. So we know very well that when the nerves contract, and then when the signals are releasing the nerves, and then the muscles contract. So exactly in this disease, that means this action is already impaired according to the damage that occurs within this neuromuscular junction. So this is the neuron, and then we have the acetylcholine in the postsynaptic, in the presynaptic space, and then once they are released, okay, they are supposed to be received. They are supposed to attach the receptors on the other side, okay, and then to cause the intended action within the muscles. And in the normal person, it is just like this. It is released, and then the receptors are here. It takes it, and then an axon is fed. Let's look at what happens in the abnormal or the neuromuscular junction that is affected by myasthenia gravis. We said it's an autoimmune disease. Autoimmune disease meaning that the antibodies react to damage the system itself. So here we have receptors are blocked by the antibody. So you see, we have our acetylcholine dots here, and then we have our receptors here at the side of the muscle, ready, waiting, suppose for acetylcholine to attach, okay, induce signal actions. But what happens is that there are antibodies. This structure here is that antibodies are already attacking the receptors. So they are already bound to receptors, so leaving no space for them acetylcholine to bind to. The acetylcholine can be released, but it has nowhere to attach to. As a result, no axons are produced and muscles become weak because no contractions can be achieved. So what happens? These are the symptoms. These people present it. Okay, there's muscle weakness, there's fatigue. Okay, even they say there's horizontal smile, and even difficulty in breathing because already muscles are contracting, and then our skeletal muscles need to contract to keep the intercostal muscles moving. The pathophysiology, of course, is autoimmune, attack on skeletal muscle, the nicotinic acetylcholine muscarinic acetylcholine receptors, resulting in 70 to 95 to 90% reduction of receptors at the neuromuscular junction. So when this percentage has been destroyed, meaning really more uh, reduction in the effects felt. We look at myasthenia gravis treatment. We say reversible cholinestrase inhibitors are used, like the neostigmine, in the treatment, but it's not a cure. This is an incurable disease, but normally we use these drugs to improve the quality of life. Okay, so lifelong treatment might be necessary. Importance of staying within the therapeutic range to manage symptoms effectively. We should not go outside the therapeutic range. There's what we call myasthenic crisis and cholinergic crisis. Myasthenic crisis occurs when there is inadequate cholinesterase inhibitors leading to weak muscles and decreased respiration. Treatment, we can use neostigmine. Hydrophonium is an ultra-short-acting cholinesterase inhibitor that reduces the risk of myasthenic crisis but also increases the risk of cholinergic crisis. Hence, it's a bit controversial in use. So the best we can use it in neostigmine. Cholinergic crisis, this occurs when excess cholinesterase inhibitors causing weak muscles and decreased respiration, decreased salivation, decreased heart rate, decreased blood pressure, and wheezing. When this happens, the treatment is we give atropine. It is an antidote also that counters the actions of the cholinergic medications, and we may also oxygen to support. Safety alert and conclusion, we said high dosage of cholinesterase inhibitors can lead to severe complications such as respiratory paralysis, can be fatal as well, and also cardiovascular collapse. Bradycardia, the heart might stop to beat. Proper management with appropriate dose and prompt intervention is essential in treating accelerated disorders and disease. So here really we have to be very strict and specific with the doses because an overdose might lead to already the outcomes we see here, the respiratory paralysis or cardiovascular collapse and can cause sudden death. Okay, thank you for being with me and see you in the next lecture. Bye bye for now.